Hi everybody, Dr. Bob Coleman back for part 2 of this case. We're going to pick up where we left off, which was the CT scan. We'll go back to that here in just a few seconds. But we want to talk about what would you do next in a case such as this. If you go back a couple of slides and you see the lab work that we've done, the venous blood gas analysis, the CT scan, your best guess diagnosis, of course, is most likely hemorrhagic pancreatitis. What would be your first intervention, admission, and ND consultation? Let's go over the differential diagnosis first before we decide what exactly we're going to do. This list is only 9 things long. However, I think if we sat down and talked and had a 1-hour session with everyone, it would clearly be more than 9 things. But I think the top 3 or 4 is something we need to talk about. The diagnosis of acute pancreatitis, of course, would be top of the list. We know that based on what we've already seen. Diabetic ketoacidosis. Diabetic ketoacidosis can be a cause of acute pancreatitis, and acute pancreatitis can trigger diabetic ketoacidosis. So 1 and 2 can be interchangeable. The patient clearly has a metabolic acidosis, a dehydration, alcohol abuse from his binging the night before, hyponatremia, hypokalemia, hypocalcemia, and anemia. One of the things I want to bring up to everyone is that if you see a hyponatremic, kalemic, and a calcemic picture like this, it's probably a good idea that you add a phosphorus. Because some of the lectures in the past and some of the literature has known that if you do have a hypophosphatemic patient, they can actually not have the ability to phosphorylate and then can end up with diaphragmatic failure and respiratory failure. So if I do have multiple electrolyte disturbances, one of the things that I will add will be a phosphorus. Again, the magnesium I'm going to go after first. Magnesium will be added onto this as well. That will be number 10. But magnesium needs to be corrected first prior to the potassium going to be correcting on its own, as well as the calcium. So if you have multiple electrolyte disturbances, always add a phosphorus, because these patients can develop a hypophosphatemic respiratory failure. If insulin is started on this patient throughout his hospital course, insulin is a polarizer, as we all know. It will definitely drop your potassium. It can also drop your other electrolytes, including your phosphorus. And I cannot give you the citation at the moment as to who wrote the articles, but in some of the critical care literature, hypophosphatemia has been linked to patients in critical disease that can develop a hypophosphatemic respiratory failure. So one of the things we want to go over is these differential diagnoses. We know that acute pancreatitis is clearly the cause of this with diabetic ketoacidosis, concomitant metabolic acidosis, and dehydration with alcohol abuse, and multiple electrolyte disturbances. So your guess diagnosis, we've discussed that already. Your first intervention is fluid support. You must support the fluids, and as well as starting to correct. Of course, the airway, breathing, circulation is something that goes way back to lifeguard years for any of us who did that. But airway, breathing, or not bleeding, but breathing and circulation, fluid hydration is very, very important. Admission, we know. I mean, the patient's going to be admitted. Consultations. Surgical consultations in patients with hemorrhagic pancreatitis would be very, very important. Pancreatitis used to be a surgical emergency long, long time ago. But now with the invention of endoscopic retrograde cholangiopancreatography, ERCP, and very aggressive GI consultations, a lot of times this is more of a medicine remission with GI and consultation. With a CAT scan that shows obliteration of the pancreas head, tail, as well as the body of the pancreas, as we can tell, this is all a hemorrhage up in here. Clearly, this would be more of a surgical issue, and clearly a general surgeon would be on consultation with this particular CAT scan. As you note, up here, along here is spared. There's no evidence of free air. There's no evidence of a bowel obstruction. The kidneys themselves look okay. The liver itself, a little homogeneous, but it looks okay. But there's no other bleeding diatheses noted here other than complete obliteration of the anatomic detail of the pancreas. So the diagnosis has already been made. Let's talk about just a pop quiz. We call it a pop quiz hot shot. Who was Dr. Ransom? I won't answer that at the moment. What are current Ransom's criteria for both patients with pancreatitis on admission and at 48 hours? Well, here they are. We were able to list them, and I used them on occasion. I mean, and this young man did meet some of these Ransom's criteria. And I still will tell, I'm a hard believer that the more Ransom's criteria you meet on admission, the worse the prognosis. Pancreatitis is not a benign disease. It can be lethal. Patients can develop an ARDS. This is one of the most common pulmonary complications of pancreatitis. So this is not a benign entity at all. And this is certainly something that is very, very serious. especially in this particular case. But initial admission and within 48 hours, the age is about the same, the white count is about the same. The LDH, as you can tell, lactate dehydrogenase will go up to about 600 after about 48 hours. Your blood sugars don't change much, but the BUN in the creatinine is something to look out for. Increased by 5 milligrams per deciliter. And a BUN of over 45, 48 hours from admission is clearly one of the Ranson's criteria to be followed closely. Hypocalcemia, if a patient is already hypocalcemic, you worry about a saponification reaction within the pancreas. The pancreas can autodigest and it can saponify. And if it saponifies, you can develop a hypocalcemia from saponification of the pancreas. A PaO2 of less than 60 on arterial blood gas or a PaO2-FiO2 ratio of less than 250, these patients have a risk of developing pulmonary complications from this. And I am a strong believer in arterial blood gas analyses on certain things, and this is clearly one of them, to check to make sure the patient's PO2 is at least 60 or higher. Fluid sequestration of over 6 liters and an albumin less than 3.2, you can tell the difference between the left and the right. Us guys working in the ED, we primarily use the initial admission, of course, and then intensivists sometimes will dive into the within 48-hour criteria based by Dr. Ramson. The other question I would have is, how long ago were Ranson's criteria actually invented? Who was Dr. Ranson and what did he do? That's something to kind of think of from a historic perspective, just exactly who this individual was. Well, that's the case. The young man was admitted to the intensive care unit, had a pretty rocky course, and to my knowledge did okay, but was in the hospital for quite a number of weeks based on this. It clearly was brought on by undiagnosed diabetes, plus the fact that he had an alcohol level that was quite high the night before, and it triggered an acute pancreatitis with metabolic acidosis. Any questions about these cases? Like I said, this is our first lecture. We're just going to roll this out a little bit. Hopefully in the other lectures to come in the future, we'll have more literature and some citations that we can go over. But if you want to email me any of your comments or concerns, that would be great. I'd appreciate any help from any of the physicians or PAs. If you guys have any additional cases for us, we would like to start putting them on tape like this and getting them out to our blog. And I think this would be a little bit easier for us for continuing medical education. Thank you for joining me. I'll see you next time.